Hey guys, so what a fun week. If you are like any other adult med-surg student, you have just realized your cardiac destiny and realized that now that you've tipped your little bit of toe in the cardiac waters, that you are not going to be able to resist more and more and more. So don't worry. We have another week, and even though our week got cut short, our weeks in cardiac got cut short, there's lots of fun still to be had. So a couple of reminders. Remember, I have student hours throughout the week. And even if it's like, there's times that I can meet if anyone was interested, if my Wednesdays that I usually have that whole day open, if that doesn't work for you, a lot of times I'm around, I'm not doing anything. But you could just let me know like if there's a certain time or day that works better for you. And remember, most of the time I have time sometimes on Monday afternoons. Wednesdays, most of the day, I'm free, Thursday mornings, and some Friday afternoons. So just let me know if there's a certain time that you want to meet, and I can try to make myself available to you. Try to come seek help before there's a problem because it's a lot harder to catch up than it is to, get ahead of things and try to figure out like how to get started in this area. It's always hard if you come to me a couple days before the test and say, I don't know, I'm lost. It's going to be a lot harder to guide you than if you come to me now. But even if you're just going to come and drop in my office hours or student hours and just say, hey, I have no clue what I'm doing, I need some help, that's what I'm here for. I'd love to guide you. Also, don't forget that you have 3 assignments that are due in a little over a week. They're due on the 7th of March, and you need to get one case study done. Remember, there's 4 options. This time I want to say it's like deep vein thrombosis or DVT, coronary artery disease, hypertension, and there's one other one. Heart failure with atrial fibrillation. So those are your 4 choices. So pick one of those and feel free to do the other ones. Remember, case studies are really helpful. For EAQs, you need to do the green lizard. There's a assignment number 2 that has CAD, hypertension, and chronic stable angina, excuse me. And so that will be your assignment for the second section. But remember, there's tons of other EAQs that are optional. Really recommend digging in those or making your own quiz. And then there's also going to be a hypertension critical thinking activity on Blackboard. Remember, you have to do all 3 of these things, and they're worth a total of 45 points. Those 45 points can make or break you, so make sure to get those done. So let's answer some follow-up questions that some of you guys had from this week. So there was questions about what is a 6-second strip? What is all this stuff that maybe was confusing? So usually in real life, you have to make sure that a strip is 6 seconds long to accurately count the heart rate. So, in this class, I told you, you don't have to worry about that. You don't have to count it out. But what that's talking about is normally I have to count so many boxes, and within those many boxes, that's how I count the heart rate. If it was longer than this many boxes, it's not going to be an accurate heart rate. So in other words, like when we were doing a lot of those practice problems, some of those strips were really long and some of them were shorter. And normally you would, as a nurse, you would have to count and make sure that you're looking over the right amount of time or the right amount. You don't want to count too many of the QRSs. But anyway, I feel like I'm already kind of getting confusing and hard to understand. I don't want you all to go in too deep with this. Just assume that every strip is 6 seconds long, like this picture kind of shows, that there's this many boxes, even if that's not true. So in other words, whatever strip you're given, if there's one on an exam, etc., you're just going to count how many QRSs there are and count and multiply that by 10. You don't need to do anything fancy. You don't need to calculate anything extra. But if you want to know more what that meant, if you're more confused now, or you thought you were okay and now you're confused, there's nothing you need to understand here except that you don't need to count any boxes when it comes to figuring out the length of the strip. So some other questions. So one of y'all, or maybe multiple of y'all, seem to have a lot of interest in pregnancy. I am not a very big specialist in pregnancy. You will learn a lot more about this next semester, but someone was asking about the risk of hypertension during pregnancy. And when you have high blood pressure during pregnancy, remember, high pressure doesn't mean good flow. So think it's going to be a flow issue. There's decreased blood flow to the placenta. You can have abruption or separation of the placenta from, where it's getting its blood supply, poor growth of the baby, premature delivery, future cardiovascular disease for the mother. And the biggest concerns are always going to be what's called preeclampsia, which leads to eclampsia, and then also stroke. And preeclampsia is where your blood pressure gets so high that you can actually get to the point where you are really high risk for seizures. And then eclampsia is where you actually start having seizures. So these moms, what happens to them, their blood pressure gets so high that they start having seizures. And the only way that they can get the seizures in this activity or get out of eclampsia is having the baby. And sometimes this is early in pregnancy. So sometimes it can mean loss of the child. So obviously this is something that we need to assess for in our pregnant mamas and make sure that we are monitoring it closely and that it's managed during their pregnancy. There was a question about the difference between atrial fibrillation and atrial flutter. These are the same thing. The only difference is that atrial flutter can be regular or irregular. So remember when we were learning about seeing whether there was the same distance between the pointy things or the QRSs, and that with atrial fibrillation, it's always regularly irregular. In other words, there's always going to be different spaces between all of those QRS complexes. In atrial flutter, it can be irregular, but it also can be regular. So remember how I was kind of talking in class that it had a more uniform, like it could have a normal heartbeat, like where atrial fibrillation is like, it's going to be very irregular. So atrial flutter can be more regular. It can, it can have less complications sometimes. But again, just remember what I said in class. You're not going to get a strip and have to say, is this flutter or fib? Because, again, that's harder for like even an experienced nurse to have to differentiate. And the treatment's going to be the same. Is it stable or not? What's their cardiac output or their blood pressure? How are they doing? We're going to treat it the same. So kind of like this chart shows, they have all the same symptoms. They can have all the same problems. So we're still going to treat it the same. There's just if you have atrial flutter, there's just a little bit of a better chance that you might not, you might be a little bit more stable. You might have a little bit more regularity. So again, really the answer is there is no difference. So difference between right-sided and left-sided heart failure. You always want to think about where the problem is. So heart failure is a problem where blood is backing up. It can't move forward. So if I have a problem with left-sided heart failure, it's talking about my left ventricle. And if fluid is backing up from my left ventricle, where does it go? That's where you need to know your heart anatomy. And I think on my Google Drive, I think there's a funny guy on YouTube that does like a heart anatomy rap. So if you haven't got your anatomy down when it comes to like the way blood flows in the heart, you might want to watch that. It's pretty entertaining. But what was I going to say? The left ventricle, like I was mentioning, where does it back up to? If it's moving forward, it's going to go out to the rest of the body. But in heart failure, it's not working right. So fluid actually backs up because the heart can't squeeze it forward. So it starts kind of backing up. Think like traffic. What happens? A bunch of cars back up, back to back. So where does traffic back up in the heart when you have left-sided heart failure? It backs up into the lungs. So when you think left heart failure, think lungs are going to be the ones that are affected. Right heart failure is the right ventricle. Normally, if the right ventricle is working well, it's going to push blood into the lungs. But when it's backing up, think, where's the traffic jam? The traffic jam is going to back up into the right atrium and then out to the rest of the body. It's going to back up where it came from. So it's going to go up into the neck, then go down into the extremities, the abdomen, and everything's going to get swollen. So think right rest of the body. Additional questions. Why do we not need to intervene in occasional PVCs? Think of it like a hiccup. Sometimes your heart's going to make mistakes. It's not a perfect creature. So, it's not really causing a problem. So there's not a lot we need to do about it if they're just occasional. But what we're going to worry about, again, is when they're frequent and when they're back to back. That's when they're going to cause a problem, because that's when we're not going to be getting perfusion or blood out. Otherwise, they're really not a problem. Again, they're kind of just, occasionally the heart gets a little excited because the heart's awesome. And so, that's what happens sometimes. So it's not something we necessarily need to treat. And then there was a lot of questions about people kind of getting overwhelmed about what they need to know for EKG. So I thought I'd break it down. You need to be able to look at a strip and know what the rhythm is. When I say what the rhythm is, I'm talking about the simple rhythms that we talked about in class. Nothing more, than the ones we discussed in class. You need to be able to calculate the rate like we practiced in class. You need to know what you're going to do about the rhythm, if anything. Some rhythms don't necessarily need to be treated. You do not need to know every possible cause for a rhythm because there are a lot. So trying to memorize, like, okay, this rhythm, who's going to get in this rhythm? Like sinus bradycardia and sinus tachycardia, I would know those because those are much more specific. And there's a lot of things that we can do. They're like modifiable things that we can do. Like remember how we talked about with sinus tachycardia, the fever, the dehydration, pain. Like I need to know that. But when it comes to all the other rhythms, the VTAC, VFib, atrial fibrillation, SVT, asystole, all of those are going to be the same, like heart disease, heart failure, electrolyte imbalances, oxygen issues, acid base imbalances, like you name it. And I'm not saying you're never going to need to know that, but that's not what I would focus in on there because you're going to spend a lot of time going down a rabbit hole and trying to memorize a long list of things that it's not as important to know necessarily why it's happening as the nurse. Like our main priority is what am I going to do about it? Like, okay, they're in this rhythm. And yes, I do need to identify the cause at some point, not me as the nurse, the doctor's really going to be working on that. But at the end of the day, I need to know in that moment, what do they need? Because in that moment, regardless of why they're in that rhythm, they're not perfusing. So you always want to think about, okay, so if I'm in this rhythm, I'm not perfusing, what do I need to do right now to get that perfusion back? And you don't have to completely understand what's going on inside. Even I don't understand everything that's happening in the rhythm. It all comes down that there's some sort of crazy electrical activity happening in the heart. It's either fibrillating or it's beating really fast. And the end goal, and no matter what the rhythm is, remember everything in dysrhythmia is there's not enough cardiac output. I'm not getting enough blood out of my beautiful heart to the rest of my body. And so therefore, my body isn't getting the perfusion or the supply of oxygen that it needs. So regardless of what's going on inside, it's not something that you need to go too in depth about. Like there's not going to be like any crazy question, and in the future a patient's not going to ask you like, well, where exactly in my heart is this happening? Why is this happening? How is this happening? Like most patients don't want to know that. They just want to feel better. So you want to do what you can to support them. And so like I said, like the kind of the description I gave you with a lot of them, like atrial fibrillation, the top of the heart going like this, ventricular fibrillation, the bottom of the heart going like this, VTAC, bottom of the heart beating really fast. Just knowing it's top or bottom, that's really what's helpful. But aside from that, it's not really important to know deep down, like, but how did this start? Why is this happening? What does it necessarily look like inside? Because honestly, it probably just looks like a beautiful electrical explosion in the heart. But at the end of the day, no matter what it is, whether it's atrial fibrillation, VTAC, VFib, there is either no or not enough cardiac output. And that's what it comes down to it when you look at it as a whole. So some other EKG questions. Someone was asking about understanding SVT. It's like sinus tachycardia, but it's faster. So the difference between this and sinus tachycardia is in sinus, remember in anything that says sinus, I should have a P wave, QRS, and a T wave or a toilet. In SVT, you're usually not going to see that P wave because it's going so fast. So I always remember SVT fast and skinny. It's greater than 150 beats per minute. It is a top of the heart problem. There's another question about what does it mean for the QRS to be skinny or fat? And the question asked, what does it mean for the P wave to be skinny or fat? And we don't worry about the P wave being skinny or fat. We only worry about the QRS being skinny or fat. The P wave, we only worry, there's other rhythms you're going to learn about in complex where they do weird things like go upside down, or that the interval between the P wave and the QRS gets longer, but we don't worry about a fat or a skinny P wave, at least not at the level that you are at now. If you ever become a cardiologist, you may need to worry about that. But I promise at this level, all you need to worry about is the QRS, skinny or fat. But anyway, what that means is the QRS is, we don't want the QRS to be greater than 0.123, which is 3 small boxes. So kind of look over here at this picture. So you can see that we're looking at this space here. What is the distance? You can see like this one in the picture, it's only 2 boxes, 2 little boxes. And so we don't want it to be more than 3 small boxes. Like I said, I promise you we're not going to give you anyone that you're like, oh, is that skinny? Is that fat? What's going on? It's going to be very obvious. We're not expecting you all to be, diagnosticians here. We just want you to be able to recognize what's common and what's deadly. And so I promise if you're freaking out and be like, oh, I can't tell if it's skinny or not, that's okay. The rhythms that you're going to have to identify, at this level are going to be ones that are going to be very obvious what the problem is. If and of course, like I mentioned, like, so that's, we don't want it to be fat. We don't want it to be greater than 3 small boxes, but we want it to be skinny, because that means either the rhythm is normal, like I'm a normal sinus tachycardia, sinus bradycardia, or I have a top of the heart problem. Because remember, if there's nothing wrong with my QRS tells me the bottom of the heart is working. My P wave tells me the top of the heart is working. And so if my P waves are missing, or if they're doing something funky like fibrillating or fluttering, then that's where there's the problem. So again, we're really using that QRS as just kind of a gauge to see, do we have a top of the heart problem or a bottom of the heart problem? And then someone asked about differentiating ventricular fibrillation and ventricular tachycardia. So ventricular tachycardia is more organized. It's fast and fat, and usually we can count the rate. It's going to look mostly like just like a bunch of V's. So it's going to be more uniform. And I have a picture on the next slide. Whereas ventricular fibrillation is more disorganized. It has fibrillatory waves. And usually you can't count the rate because you're like, where are the QRS complexes? So you can kind of see here, look at this top, look how uniform this is. I can count these pointy things. Over here, like I can count some of these pointy things, but some of them I'm like, wait, what is this? So VTAC on the top, VFib on the bottom. Organized, disorganized. All right, so then someone else also asked about how to prioritize. So excuse me, on my slides under each disease process that we talk about is nursing priorities. So like usually near the end, near collaborative care, what can I do as the nurse? What I recommend you do is you take each of the things I listed and write out interventions that are important. And then, you really have to think about them in scenarios. And I can't give you every possible scenario. Even if I wanted to try to help you, I can't give you every possible scenario because they're endless. But we're really just trying to help you to think about kill factor. So after you kind of write out these interventions or possible things you might need to do, you want to think about what the actual problem is. So what do you call it? Like, let's say, for example, we talk about, like chronic stable angina. So some of the priorities are having adequate perfusion to my heart, of course, or getting adequate perfusion to my blood vessels that supply my heart. And so if that's my main problem, if they're not working, then I'm not getting blood flow or oxygen to my heart, and my heart's going to stop, and that's the end of my life. So that's going to be a real problem. So a couple little, like when you think about what the actual problem is, then you can start thinking about like, okay, if that's what my problem is, then like, what's going to be my solution, and how serious is this? Because, there's going to be some priorities that like, hey, well, they're not going to be as serious as, hey, my heart can stop. So a couple general tools, and again, like these work in most situations, but I know that all of us are overthinkers, but maybe hopefully this will help to kind of guide you a little bit. If it's a life and death emergency, I'm always going to treat the patient first. So like, for example, when we talked back about diabetes, about hypoglycemia, if a patient's unconscious, I can't even wake them up, I'm not going to sit around and assess them first. I'm going to treat their problem first. But if the patient's stable, or it's not a life and death situation, even if it's a critical situation, but not life or death, then I'm going to assess first. So if they're kind of lethargic and showing signs that they're probably hypoglycemic, I can check a blood sugar first. What do you call it? A lot of this, it applies to a lot of the stuff we talk about with dysrhythmias. So like if I have a patient that's in ventricular fibrillation, I'm not going to sit there and aside from of course we almost, a lot of times we're not even looking at the rhythm. We're just like, do they have a pulse? But if I have a patient that doesn't have a pulse, I'm not going to sit there and be like, let me do a head to toe assessment. No, I'm going to treat them first. I'm going to use my protocols and do my ACLS, my CPR, give drugs, defibrillate if it's indicated, etc. But if the patient's stable or not in a life and death situation, but it's critical, then I want to assess. Remember kind of how we talked about with dysrhythmias, how we kind of look, how are they tolerating it? What symptoms are they having? What's their blood pressure? What's their oxygenation? And then usually we don't want to call the doctor, usually, again, without assessing first. Because here's the thing, when I call the doctor to tell them, hey, there's been a change to the patient, I want to usually have all the data that I need first, because then they're going to just hang up on me and tell me, Call me back when you have the information I need. The only time we call them first is when it's an emergency, and doing assessments would delay life-saving treatment. So I'm not going to sit there and be like, my patient doesn't have a pulse, let me call the doctor. Like, no, I'm going to treat that patient. Someone else hopefully will call the doctor for me while I'm doing CPR in real life. But it's going to first, I have to treat that patient. So yeah, a lot of times this is where students get a little bit confused because, like they're not sure. They're like, oh, this is kind of serious, but is this like life and death serious? So I try to, reiterate which ones are kind of those like situations where it's like, hey, we're not going to wait around, or hey, we need to do a really good assessment and see what's going on here. Because remember, kind of like what we talked about, a lot of times some patients can look really sick, and look like they have like a lot of bad stuff going on with them, but that's just how they look. Like they just generally look very sick, or they have chronic conditions like COPD, CHF. Like a lot of these patients, they don't tolerate activity well, they might not be breathing great, but they're doing okay for the condition that they have. So in those situations, usually we assess first. How are they doing? What are their symptoms? What are they experiencing? But if they're starting to show signs that they're getting zero or limited perfusion, they're what do you call it? There's a major change in their assessment. Usually that's where I'm going to need to call the doctor and be like, hey, what do you call it? We need to do something about this or change something to kind of help this patient a little bit more. So yeah, so we'll get more into this. And like I said, I really think those critical thinking scenarios that I posted on my Google Drive will be helpful to you guys. Try to look through some of those, send some of your answers to me, or meet with me during my student hours and let's work on them some together. I'm here to help in any way possible. And then I also mentioned, it's really important to do practice questions and case studies to really think, what are their scenarios? And if you ever come across one, you're like, I don't understand why this was more important than this, send it to me. Let's talk about it. Because sometimes you don't like, I can't really teach, like there's not one way to teach prioritization. Because like I said, every situation is a little bit different. But we're just trying to teach you how to think, how to use kind of like, okay, in this moment, what's most important. And so, as a whole, if I can start working with you more individually, and like we can talk about these things, you can start to kind of get that thinking brain that says like you can start to identify it a little bit easier. So in other words, the short answer for how to prioritize is a case by case basis, but hopefully some of these strategies helped a little bit. And again, practice, practice, practice will make such a difference for you. So there's lots of great resources. I'm going to go to my Google Drive here in a second just to kind of show you some of my favorites right now. And I'm not sitting here advertising for myself because I promise I don't get any profit off of these, but I just wanted to let you know your options. Because a lot of people I don't think know a lot about the Google Drive, or they know about it, but they get overwhelmed in it and don't know where to start. So there's lots of options and resources. You always want to find a balance. Too many resources is a thing. Like, you don't need to be doing every single thing on my Google Drive or every single video or every single thing I post, but you need to be finding and honing in on areas that you're weak. So doing that brain dump where I told you to write down everything you know and then seeing where your weaknesses are, that's a great place to start. You want to target the things that you're missing. Or if you're doing a bunch of practice questions and getting a bunch of the same kind wrong, you need to go read a little bit more about that or do a worksheet on it. Do something different. You need to do a mix of, you have to do some reading in the book, as much as I know everyone hates it. Do some practice questions. Remember, the people that did the best on this last exam, they had a study group and they did a ton of EAQs. 10 to 15 a day will go very far for you. Remember, do a mix of the purple lizard and the green lizard. And then you need to do activities to get the information out of your head. Even if you're reading and doing practice questions, until you do more activities to really test your knowledge without your notes, talk about it, teach it, live this information, it's not going to be as helpful to you. And like I brought up, try to break things up into small pieces. So instead of trying to read and learn 20 meds in a day, do one med a day, one med in one lab, and then it doesn't seem so overwhelming. Have a study plan for the day and then try to focus on like in general, like be like, okay, today I want to cover heart failure, the basics, like what we went over in class. And then like each 30 minutes be like, okay, for this 30 minutes or this hour, I want to read about drugs. For this hour, I want to do EAQs for this hour. And I don't mean like map that out, but I mean, every time a new hour comes up, set a timer or something in your phone and be like, okay, it's time to switch to something else. Instead of trying to do that back to back to back 5 hours straight of the same thing. So Going to my Google Drive over here, I have my theory resources. I'm gonna go to cardiovascular, the best section. So I have a variety of things here. So this week we did EKG and dysrhythmias. And so there's a variety of worksheets, nursing.com informational. There's also these fill-in worksheets. So there's multiple worksheets here where you can practice your dysrhythmias and practice your strips. You're welcome to send those to me if you want any feedback. Then there's also informational worksheets. So if you need kind of a breakdown, there's this document that's called Heart Rhythms Breaking It Down. And it literally has each one and says, what am I? What am I worried about? How will I treat it? So this might be helpful to kind of break down, to kind of look at all of those, in a more simple way. And then there's also like a rhythms table. There's a big EKG packet from JPS, which is a lot more in depth. And then there's a dysrhythmia drug table. Additionally, aside from EKG and dysrhythmia stuff, there's also a lot of general worksheets. So if you go into fill-in worksheets, there's a ton of cardiovascular. Of course, I have a lot of cardiovascular stuff because I love it. But there's a lot of med stuff. So people always complain about not having enough stuff on meds, but there's a ton of resources here. There's a worksheet here that's called When Should You Hold It? And that talks about like, hey, okay, here's a medication. When are going to be times you're going to need to hold it? Or maybe do further assessments before you give it. So that's a really good practice. There's also the this cardiac med case study, which will help kind of seeing giving meds together, what you need to consider, or before giving like a bunch of meds together. There's of course the matching. There's a variety. I think there's 3 or 4 different tables you can fill out with meds. And I think those are great. Just when you do these, don't fill up the whole box, bullet points, just keep it simple. But lots of good things here. And then the other big thing that I don't think as many people are using because it's long is there's this cumulative cardiac worksheet. Now I have a cumulative worksheet for each section. If you start filling that out, and again, that's something when you use all these resources that people always say, oh, it's going to take forever for me to fill out. You don't have to fill it all out in one sitting. Spend about 30 minutes on it, whatever you get done, and then put it down and pick it up later, a couple hours later, the next day, whatever, but fill it out a little bit at a time. It doesn't seem so overwhelming, but this cumulative cardiac worksheet might help to break down and kind of see where you're at. And this is maybe something good to do even as we're approaching this last week, to kind of see where you're at, where the holes still are. If you can fill a lot of this out without your notes and stuff like that, that's great. And if you have any questions or want to send any of it to me, I would love to help in any way. Well, that is just a very basic overview, but I hope this was a good start to your weekend to get you ready for more cardiac next week and more fun. So it was a pleasure. I'll see you guys next week.